Welcome back to this week's episode of Promising Young Surgeon. I'm your host, Dr. Frances Mei Hardin, and today we are tackling such an important topic. Wellness, not only for physicians, but also for patients and their caregivers. So this is a new area for us. Of course, we all know that medicine can be a very stressful and sometimes traumatic environment for all involved. But up until now, we have been focusing on the stories and the experiences of the providers. Today, I'm so excited to welcome our guest who will help us understand how we can better serve the patient and the patient caregiver side as well, just in part by understanding their journey, but also by being able to provide helpful resources to them. And so it's truly my pleasure to introduce our guest today, Christen Mullane. Christen Mullane, Ph.D., is a psychologist, writer, and human who cares about making healthcare healing. She is also a certified meditation teacher. She completed her graduate studies in psychology through the University of Tennessee in Knoxville and her meditation teacher training through the Lab of Meditation in Vancouver, Canada. Over the course of her clinical career, she has worked in medical settings, including emergency rooms, primary care clinics, ICUs, palliative care clinics, cancer clinics, and skilled nursing facilities. She has supported patients through diverse experiences such as COPD, strokes, heart attacks, cancer diagnoses, and treatments, complicated births, POTS, diabetes, Crohn's, and colitis, as well as medical errors and medication reactions. She's deeply passionate about supporting individuals who have experienced and witnessed stressful and traumatic medical events, whether they identify as the patient, the caregiver, or healthcare provider. Her upcoming book, Medical Stress and Trauma, releases on February 11th, 2025. The purpose of the book is to allow the reader to discover tools to heal from medical trauma and stress. It's a mindfulness-based workbook that offers practical strategies, meditations, and case studies to help the patients, caregivers, and clinicians reclaim safety, manage their pain, and rebuild resilience. Christen, thank you so much for joining me today, and welcome to Promising Young Surgeon.
I'm so happy to be here. Thank you for having me.
Of course, I'm so excited for your book, and I know we're going to do a deep dive today, but I think that you have hit on something that's so important and actually often overlooked, because even from the physician side, speaking from the surgeon side of things, we don't spend a ton of time contemplating or learning about the patient and the patient caregiver experience.
Yeah, I think it's the way I sort of view medical stress is systemically. And I think when we're working in systems where trauma happens, whether it's, a medical system or otherwise, a family system, everybody in that system can be harmed in some way. And so I know I really appreciate y'all's focus here on the provider experience, because that needs attention. Like burnout, in one opinion piece I read, could be understood as a trauma reaction in a lot of ways. And then we can think about providers who've experienced vicarious traumatization and things like that too. And then any sort of medical experience, of course, is going to have life impacts for patients and their caregivers that extend past the exam room. So as we're working through this healthcare system, we all might be hurting, but we also all have the chance to help each other kind of heal and move through this in a better way, move towards one another.
That's so true. And I like the idea of the interconnectedness of like all three of these players, really, the provider, the patient, and the caregiver, because like certainly I've personally experienced, and I know other healthcare providers, right? Like we certainly sometimes face situations where the diagnosis or the pathophysiology, those are the facts. Somebody is ill or injured, perhaps a prognosis isn't good. And it's tough because step one is the ability, I think, for the doctor to recognize that somebody's really hurting, right? Like I see my patient suffering. I just gave them news. I see that they're suffering. Maybe I see that their caregiver is suffering as well. And not everybody even, give space for that step. But that's one important step. But what I think is great and what I'm excited to get into with you today is like part 2, building beyond that, because sometimes just the interaction ends there. And it's like the provider's like, man, I wish I could help you more than I already have, which is to give you all the information.
Mm-hmm. I do think information is a really important and valid step. And I really appreciate your point about recognizing pain and suffering in its different forms, because I do think in any of our roles, like psychology included, we can sort of become siloed, right? And think of ourselves as a specialist in one particular part of the patient experience. But if we can break that down a little bit and break down silos, just like we're doing even in this call today, have cross-disciplinary, interdisciplinary moments where we can talk about a wholeness of the patient experience. I do think that matters deeply to patients. It really does. Because what I hear a lot in my practice is people who are so deeply grateful for the physicians on their team and yet still feel like they're not fully understood, which is part of we could talk about what healing actually means, but part of what I think of is feeling deeply witnessed in our experience. I think let's walk it through.
Totally. Well, exactly. It's like the rabbit hole goes pretty deep because I think that in as much as people can only meet you as far as they've met themselves, like the reality is that healthcare providers are human beings. And so if they are uncomfortable with the hard feelings, even within themselves, they're going to be uncomfortable with hard feelings in another person, which that may be the patient, it may be the caregiver of the patient, just being able to meet somebody in that space. But I do, it took me a long time, I think, to build those skills over years. And I definitely cheerlead anyone who even cares enough to try to build this skill set, right? And this ability to have that connectedness. Because again, it's not baked into the medical school curriculum or anything like that. Certainly not baked into residency curriculum.
That's such a good point. Like I think there's in the mindfulness work that I've done, there's a distinction kind of between being with and working with. And so much of what medical professionals are trained to do is to work with the body, like to diagnose, to treat, to kind of be with the biology in a way that involves intervention. There's also being with the person in their emotional state, in, the struggle that they might be facing in the rest of their lives when it comes to trying to become health aware, increase health literacy, trying to navigate a medical system that's incredibly complex, trying to communicate across different providers who are doing different things in their care, trying to then go back into their neighborhood and their family system where access to health information and options for behaviors that support health might be really limited. There's just a lot to unpack there in terms of where this can all break down. And so, any little bit of awareness building we can do is going to help our patients in the long run. And it is hard to do this, to look within ourselves too and say, okay, where are my limits? Where are my edges here as a provider? What's hard for me? And what's motivating me to move past those? Like to move towards difficult conversations with patients. And there are so many of those. Like, not only are there the conversations about the diagnosis, which can be hard enough to make sure you're getting it across clearly what's going on in a pathology report or whatever, translating the data of medicine into language that fits a human experience. That's hard. There might be mistakes or errors or hangups or miscommunication moments. Those are super difficult to approach. And I don't know how many training programs really offer training and guidance in how to have those conversations. I was just watching a documentary the other day called To Err is Human. And they do touch in that documentary on some ways we can train towards those conversations. So some examples that they gave in the film were like having a room of sort of horrors where there's a mannequin, so it's not an actual patient, but who they have 10 minutes to identify all the different kind of errors in the room.
Oh.
Yeah. And then like another kind of part of training in a hospital they featured was to sit down with trainees, with practice patients, and to have the trainee talk about a medical error that happened, like a miss on a report, things like that. And so I do think efforts are being made, right, to be able to have these difficult conversations. And one of the difficult conversations we can improve on is when the medical experience itself has been traumatic in some way. And it's very difficult to look at. So that could come from medical errors. It could come from things like ICU stays. It can really happen at any level of the patient experience. And I think, when people are coming into these medical systems with full trust, and as providers, we want them to do that, it can be really scary to look at the places where trust can kind of break down, or where things happen that we don't want to have happen. But I think that's really important to begin to do. Mm-hmm.
No, absolutely. And we'll try to make this, at least for the sake of the conversation, like bite-sizable enough that we can walk through this scenario. But you're right, because just big picture, I will definitely say that medicine, the practice of medicine, the receipt of medicine, the patient and caregiver experience, it can be devastating and traumatic enough when everything goes perfectly.
Right.
And that's more of where we'll start our conversation too. But exactly like you're saying, it's that's when everything goes according to plan and no errors are made and no balls are dropped. Even though, to err is so human. So, I would love to just basically jump into I think to structure this, I'll just go over a common clinical scenario that I see all the time in clinic. And there's a multitude of versions of this really across, I think all medical practices, which is going to be a new diagnosis through treatment and through the post-treatment. And we'll look at all of those phases and then kind of the physician, the patient, and the caregiver experiences with really, I think, emphasis on patient and caregiver. But again, what I love about a lot of your work and the workbook is how all three angles are really represented and kind of addressed.
Yeah, my dream for healthcare is that we can get patient, caregiver, and provider in the room together and really, come away from that conversation feeling like something healing has happened for everybody in the room. And I do think that happens in healthcare. I'd love to have it keep happening and more and more and more, Yeah.
Yes. I'd love for it to happen more. I'd love for it to be incentivized because, I agree with you. Absolutely. Philosophically, 1,000,000% agree with you. But a lot of us have the very real daily issues of facing RVUs, how many, and also just how much time are you allowed with a patient. And I would love to speak to that part actually. So as we walk through the scenario, I would like to tell you how that is booked in terms of a time slot in your schedule.
Yeah.
So we'll just use the example of a new patient. And again, I'm a general ENT for those of you who are newer here. So it's just bread and butter, the full gamut of ENT in a rural community setting. So let's imagine that a 60-year-old gentleman, he comes in to clinic and the referral is just for dysphagia. And so it says dysphagia on the referral paperwork, which means basically trouble swallowing. Odynophagia is pain with swallowing. But they're just coming in with some kind of swallowing issue. He is accompanied by his wife. His wife is the one who really strongly encouraged and then ultimately told him to attend this appointment. So, we have a gentleman who's kind of this has been going on at least a year, if not more. I don't know. And then his wife says, well, I was only told about it about a month and a half ago. And that's what led to us seeking care, which is how we ended up here. Otherwise, not too much going on. Although let's say that on review of systems, we start getting into a conversation and they're yeah, I mean, occasionally, maybe if I brush my teeth really far back in the molars, yes, I have noticed a little bit of blood before, something like that. And they're yeah, I guess I have some ear pain on the right side, but not thinking too much of that. And then in terms of maybe a strong tobacco use history, something like that. So for these cases, we do as standard practice of care, we will scope them in clinic. So we just put a little numbing medicine in the nose and we sit, and I explain to them, I say, if you're on board, I'd like to scope you today. This is what it does. We stick a teeny camera down your nose. It feels like somebody's picking your nose with a noodle. And then we look all the way to the back of the nose, and we can turn down and look at your whole back of your throat and your whole voice box. That's what it'll let us like directly visualize today. And then we'll look at the pictures together because we have really beautiful scope towers in clinic. So, I mean, then we, it's all saved right there, and we physically bring up those pictures and watch the video together. And so, they're like, yeah, go ahead. And this person, of course, has no imaging, has not had any workup to date. But then on the scope exam, let's say we find a 2-centimeter base of tongue tumor. And this is not uncommon at all. Like, yes, I said in the story, let's imagine this person does have a tobacco use history and things like that, but we are in an HPV epidemic as well. So what's interesting about some of these patients is that they've never smoked and not really used much alcohol in their whole life, but yet they're coming back with these HPV positive base of tongue and tonsil squamous cell carcinomas, which is a type of cancer. It's the commonest head and neck cancer. Like, I think a lot of people would be negatively surprised to know how prevalent like this really is. So that's the case. So we're looking at that. It basically is like a big ulcer or an exophytic tumor at the base of tongue. But now we're all seeing it, and I can't hide, I wouldn't hide it from anyone, but also I can't, it's on the picture that we're all viewing together on a big screen. Let's say on their neck exam that honestly the neck feels fine. Like there's no big lymph nodes or big masses in the neck. Fine. So now this is the first of many difficult conversations. And I'm grateful to have like the resources to where I have those pictures to show people. Cause honestly, sometimes, and especially if they don't feel that bad, they may not even, they'd be like, what? Prove it that I have a mass back there. It's like, we're going to look at this picture together. And I tell them, I say, okay, there's one spot that we're looking at here. I freeze on that frame. And I say, I do need to tell you, I'm worried. I say, this is suspicious for a cancer. Of course, we got to prove it. That's our job. And so to prove it, we get a biopsy. I'd also like to get a CT scan of your neck. I really tell them like those are the next two steps. Number one being tissue biopsy. We have to prove what it is one way or the other. And then number two is we're going to get a picture of you. So that's how that conversation goes. But like I said, the first words out of my mouth basically are like, hey, we're looking at the same thing here. You see how everything else is very nice and pink, pretty smooth, and then you see this. And yeah, they're looking at the maybe even bloody thing, the mass that I'm looking at. So that is not me giving them the diagnosis. Although again, it's so common and they're like not pathognomonic to where it's automatically this, but it can be very, very suspicious for this. And occasionally people will say, well, is it possible it isn't cancer? And I will tell them at that point, I will say, sure, anything's possible, but the way we have to think about these things and really work them up is that this is probably cancer until proven otherwise. We got to do our due diligence for you. So just kind of, that's point one in the story. And if you wanted to do a freeze frame and we can talk about, I know it's not easy on the patient, the caregiver. I have given that talk hundreds of times now. So I'm pretty facile at that talk.
Yeah, I think it's interesting to think through, one of the pieces you're touching on is how, as providers, we can be habituated to certain conversations and to certain environments and to certain images in ways that our patients aren't. It's beginner's time for them every time, so you're navigating that gap in experience. I think I would also just sort of wonder about what level of briefing you might have had as a provider going into that room about the family dynamics you might be walking into, or maybe another place in space that I'm just kind of curious about is, maybe listeners can be curious with me here, is as we're looking through medical records, is there some part of our attention that can be with the entirety of what this might be like for a person? Like not just looking for the medical history, but also sort of recognizing, holy moly, right? This person has been either outside of the medical system entirely, and this might be the first conversation with them, or they've been in appointment after appointment after appointment, and this has been missed or not talked about. Like just sort of thinking about what you've got to go on before you even go in that room to have that conversation, and maybe to start looking at medical records, with this concept of beginner's mind, just to come back to the mindfulness stuff, which is what's in the workbook. So that's why I'm doing that. But what beginner's mind really means is looking at this like it's the first time you've ever seen a patient, you've ever seen this diagnosis. So there's things that happen before that conversation happens that I think we can look at as a field too.
Totally.
Yeah.
Totally. No, and I think that's really brilliant. I'm sure at least some of our listeners who have taken care of patients like in these populations, they'll recognize, like, let's say with that guy, and we'll use this guy as an example, that he is otherwise previously perfectly healthy. Like this man is on no medications. He's pretty active. He's very involved work-wise, career-wise, community-wise, family-wise. And so this is an active, healthy person until now kind of some earth-shattering news is being delivered. What I will say that has helped me, because I totally agree with you. And yes, one element of reviewing the info I have before I walk in the room is I already have like my top 3, suspicions before I even walk in. And statistically, that story, you need to prove that that's not cancer before you can kind of even move on. But another one, and this helps so much when we have like a great team in clinic who, again, like they love ENT as well, like really care about our patients, are also invested in this, to where occasionally like the nurse will say to me after she's roomed the patient, like, this gentleman and his wife are very anxious. Right. Because if she says that, actually, then I will in turn say to one of my nurses or potentially, I sometimes make them aware. I say, hey, I'm going into a room now, because there's like 3 rooms in clinic that all have patients in them waiting to see me. And I'll tell them, I'll say, hey, I'm going into this room. And I say, I'm worried that this might be a cancer. Like I'll pre-tell them, that's part of being prepared, because what if it's like 25 minutes later and I'm in there and they are understandably tearful, but I've answered all my questions, but they actually need someone to hold their hand. Well, we we care about that as a team, and there is a role for other team members. I mean, I wish we work together in clinic. Yeah. Obviously we're separated by states, but so we don't have like a PhD with us to do some of this really important work. But obviously it still means a lot if we can then finagle it to where a nurse is holding their hand and just reiterating all those things that I've already told them maybe now 2 or 3 times. But again, as I described, there's all these pressures, like there are 2 other clinic rooms waiting to be seen. And I want everyone to know that, like, yes, new patient visits can be 30 minutes, but typically what happens is double bookings. So realistically, I just want on the provider side to put it out there that like, this is a 15-minute slot, if that, that I'm being given to have
your
that
problem list might be like 20 deep, and you're supposed to maybe, depending on your role, whether you're ENT or primary care, like maybe get through that entire problem list in a visit too. I think there is real, it's harrowing to have a healing conversation in a time limit.
Under a time crunch.
Right. Like that just adds this pressure to the whole situation for everybody involved, like to get the patient to be able to metabolize this enough to have their questions answered, because it may be months before they see you again. Like there's a piece of the caregiver not knowing necessarily what to advocate for or what questions to ask. Like, and then there's you as the provider in the room recognizing you've got 3 more people in the, in the next exam rooms. And so this is why I think we need to perspective take well on all sides, because I do think there can be a shortfall on the patient or caregiver side in the ability to perspective take for physicians and healthcare providers. And the onus may feel sometimes like it's on the healthcare provider because we're in a position of some power, like we hold access to information, we're within the system itself. Like to recognize that we need to bear the onus of that perspective taking, and sort of be responsible for asking the questions and eliciting the information. But I think there's room on the other side of the aisle too for patients to step towards and recognize that, like, hey, we have to be a team around this whole idea. And that's also kind of fraught when medical trauma has happened. Like, just to sort of, if this gentleman had a history of different interactions with different providers that aren't even you, but they'd gone poorly in some kind of way, their ability to step towards you, trust you, believe you about a diagnosis, like all of those things can be fractured. So it's not easy. I'm not going to sit here and say, like, just read my workbook even and it'll fix the whole thing. But I do think we need more tools and techniques to be able to do that well. And so as you're kind of walking me through this particular person, I mean, one of the things I think we can do is learn about what it looks like to kind of be distressed. And ideally, that is part of clinical training on some level. Like, if you see a patient starting to avoid eye contact with you, or if they have trouble breathing, or they become tearful, like, we know some of the signs of distress. And then to normalize right from the get-go, even if you don't see those, I would say, like, even if the patient isn't visibly distressed, to be able to say to them, hey, it's really normal to experience grief when something like this happens. And I wouldn't even necessarily use the language of trauma in that moment, because that can be distancing for some people. But grief feels really normal. And that's kind of what we're trying to do from the get-go, is to normalize having emotional reactions to a diagnosis and to potentially need support afterwards. So it's hard because it depends on the patient too. For some people, it's very validating to hear something labeled as traumatizing. You can always ask too, like, it's really natural to grieve. And sometimes people even find diagnoses like this traumatic. What kind of language do you want me to use as we talk about it together today? So there might be ways in the room right there to do just enough in just a few minutes to help that person know that it's okay to have reactions, that there's resources for support on the other side.
Totally.
Yeah.
I think that, and like I will say typically, so at the end of this visit, again, this is like the first time we've met, that we don't have any imaging, we don't have any tissue biopsy. So we don't have a formal diagnosis yet. And I will say, like, I know this is a lot, right? Because we just sit there. And I mean, I'll sit there quietly, usually try and give them, a minute or two, or usually the caregiver comes up with their questions while the patient's still sitting there a little bit shell-shocked, totally understandably. I did want to mention one thing that I thought, I totally agree with you. You talked about, like, the beginner's mind. And I literally will go as far, if I am showing someone a scope exam and it has like big findings on it, like pretty significant, pretty meaningful, like I'm giving them big news, I will log into the computer for that. I'm not typically logged in. I don't do my notes in the room or anything, but I'll log on just to Google a normal flexible scope base of tongue exam. I'll pull that up on Google. And that helps a lot, because agreed, like, most people have just never seen a scope before. So they're kind of like, this all looks weird. Everything's like pink in a weird shape, down here. And so, but by pulling up the Google image, and their image is still up on the tower, and I have a computer showing, and I tell them, like, this is normal, this is what Google is saying it's normal. And I agree with that. Like, I've selected this image. Now they're like, okay, yes, I can see that there's a mass there and there shouldn't be any blood there. So I really, I want to move on to the next two quick points in time, just to get people walking through this journey with us, because, unfortunately, it's not going to get any easier. So, okay, we're there. Then we go to surgery, typically like a direct laryngoscopy and biopsy. That's all pretty standard. So that's the tissue biopsy part. And in the meantime, sometime that week, they're getting a CT scan outpatient. After the surgery, we do always go and talk to family afterwards. So that's actually an interesting one-on-one caregiver conversation. That's the surgeon and the caregiver. Patient is waking up from anesthesia. They're on like cloud 9 somewhere else, recovering in the PACU.
Right.
But yes, the surgeon caregiver, like one-on-one, or sometimes multiple family members are there. They've had time to kind of process, and they're like, okay, was it what we thought? And you'd typically say, okay, there were no surprises during surgery, but it looks like what we thought, which is that it's a squamous cell carcinoma. We'll see you in a week, go over all the final path and all the CT scans at that time. Often I find that caregivers will have like a list of questions. At that point, at that post-op little like conversation consultant room visit. So we address those. And what's nice is there's not, sometimes there's not as much of a time crunch on that. Like that's kind of nice. It's almost like, it's in the hospital, it's in a different kind of setting. Unless you have another case that you have to run and get to, sometimes you can sit and talk for longer there. It's unstructured time. But then we have the post-op visit, which that's the 1 week after surgery. Now it should really have sunk in for everyone.
Yeah. Yeah, the timeline you're describing is something that I think is also what we're reckoning with, because, even if the 5 stages of grief and grieving aren't totally right on all the time, that first initial couple of stages, it takes time to kind of move through. So what I'm referring to is Elizabeth Kubler-Ross's work around like the 5 sort of stages: denial, anger, bargaining, acceptance is the last one, depression's right before that. But we can be in multiple of those stages at once. We can travel through one and then backtrack into one we'd been into already, thought we'd moved through already. So acceptance is a real wrestling match. And I imagine, for you as a provider going into that room, it's kind of unpredictable what you might witness. Like some people may still be shocked in those first initial couple of visits. And in that first phase, it's actually really adaptive to be in denial and to push away a reality, because if we can find a solution to what we're facing, we're going to find it. Same thing with anger. Like anger is our warrior, and it's also what harnesses us, what can, to our advocate, our inner advocate or protector. And at the same time, like if those phases aren't really processed through, what you may get as a provider is like a blank stare, or somebody who's really going off at the hilt, because the anger is getting projected out at the healthcare system, and all the fear they've felt is like coming out at you. So I think we can know these things are normal, and it doesn't make it any easier to be with them a lot of the time. Yeah. So earlier you were talking about the importance of kind of interdisciplinary and team-based care. And I think that's one of the things we can also keep moving towards, is really building strong teams that are trauma aware, that recognize that the different parts of this experience are going to be stressful for everybody involved. And so whether you're involving chaplains in that work or mental health providers as a part of the team, like I really do hope that more and more healthcare systems start to build that. And you mentioned that this would be in sort of a rural setting too. And that's hard. It's hard to attract providers to those settings. Sometimes it's hard to build those teams. And so maybe we can start to leverage technologies and Zoom and things like that, like more be creative in how we work across the aisle with other disciplines.
Totally.
Yeah.
Totally. What I think is unique about, and I still think that this is a good example scenario, because like what's going to happen after that post-op visit is that they are going to the cancer center. Because let's say, again, for the purposes of this like hypothetical, let's say now we have solidified the diagnosis. The tissue diagnosis is of squamous cell carcinoma, base of tongue. It was P16 positive on testing, which means it's an HPV, like this epidemic type of oropharyngeal cancer. So now the primary treatment in this case for this patient, they're going to do primary chemoradiation. And when I say primary chemoradiation, that just means the treatment's going to be chemoradiation. There are a lot of different versions of this that they're technical. We won't go into it, but that's where you can have like primary surgery with adjuvant radiation. Well, that means that you're going to have surgery. That's your treatment. And then there will be some like add-on radiation. That's the adjuvant part. But in this case, what's interesting about like some of these is that this is pretty straightforward. So I've made the diagnosis. I've staged it now because we have like the CT scan of them. We ordered a PET scan of them after the biopsy came back. And so now we have like scans of their whole body. We know that it hasn't metastasized anywhere. We know that this is, just like a T2 base of tongue, and they're going to go get chemoradiation. So we have a wonderful cancer center, thankfully, like in our area, and they would go there and they would meet radiation oncology, hematology oncology, and the cancer center will have, thankfully, more resources than like an outpatient general ENT clinic. Because like I said, we do take the extra time to like bring nursing in, to have more people, more like caring people even there to like hold hands during a scope, hold the caregiver's hand, provide tissues. But we certainly don't have some of these like broader resources, because especially with head and neck cancer, nutrition is a massive one, speech language pathology, a huge member of the team that we don't have like within, our roof in clinic, but the cancer center can help coordinate like some of these bigger needs.
Yeah.
So I liked your point about, I think that really any language about grief, and I need to try this. I need to like see how I can work this into my practice. But to me, that would come potentially at this conversation, that like the post-op visit, because now we have a true diagnosis. I mean, you'd hate to, I never want to be the person that's like, no, this is for sure cancer. And then like the biopsy shows the 1 in a million. I don't see it a lot where you really could have sworn it was cancer and then it wasn't. But what I have seen is this, which is that you thought it was a straightforward squamous cell carcinoma, kind of the common type. And then on biopsy, it was actually something much more aggressive, infiltrative, something much worse, like a worse, different cancer. So I find it best to just really hammer home, like, yes, my suspicion's very high. I'm worried about you, but we're going to take good care of you and we're going to get the biopsy. And then I just try to give them the correct, pathology before we even get into the grieving process. I guess I would love to know your opinion, because I feel like when I walk into that post-op visit, because again, this is going to be the last time that I'll see them for a while. We'll talk about next steps after, but like I'm about to just kind of give them the info, hold their hand again, and make sure that they get onto the cancer center for chemotherapy and radiation therapy. But I walk in and I'm very solutions oriented. That's how I would describe me. And when I talk to patients, I have just found, at least in my like 8 years of doing this, that appears to be something that people respond to well. Because I'm not like a unrealistically positive person, but I do think like when I approach this conversation, I try to stay very solutions focused, very like, these are the next couple steps.
Yeah.
Right? Like you're doing great, because I often can see the patient and or the caregiver are in distress. Or sometimes what I see, and we'll say in this hypothetical situation at the post-op visit, that the patient himself, he's muted. He's just a little bit like shut down. So I don't know where along the grieving process he is, but like he's just kind of shut down. I'm not getting a ton, but I am getting from the caregiver a pretty high level of distress. She's tearful, understandably. She has a lot of questions, understandably. So I come ready with all these answers to these questions, and I'm just harping on over and over. Our cancer center, they do a good job, and you'll be well taken care of. Like we all care. We're going to take good care of you. And these are the next X, Y, and Z. And we kind of keep it to that.
Yeah, I do think keeping a message pretty simple and using some repetition often can be really helpful when emotions are high, because, both people in the room, caregiver and patient, are likely working through some level of emotional process that may make it really hard to hang on to information in that moment. On my side of kind of work, what I try to help people do is to clarify like their top 3 questions for a visit. And so this is what patients and caregivers can be doing. Like identify your top 3 things that you want to get answered, because we know time constraints are present. Other things that I think are really helpful for patients is to have a safety and coping plan in place for medical visits. like really thinking about what is going to help them move through that medical visit in a well-regulated way as much as possible. Because I think, it's interesting how you're describing the patient being withdrawn and in themselves, which leaves the caregiver to be out in the world navigating that. I wouldn't, sometimes what I think providers may miss is with the quiet patients, like, right? Like there's something going on in there still, whether it is kind of reckoning with their own mortality or maybe a lack of self-efficacy in navigating medical systems and, or not knowing what to ask, or concern about burdensomeness. That's a huge one for people. Like, I don't want to make waves. I'm just going to stay kind of quiet. There's a lot of concern too about being a good patient a lot of the time. Like, I want to just do all the things because, for one thing, my life is riding on it potentially. And for another thing, I really don't want to do anything to make my providers mad at me. They have my life in their hands. And, people are socialized too to kind of be good and kind and trusting and in a lot of ways. So there could be a lot going on even with relatively quiet patients. And so, and then there's the flip of this. There's the folks who are not quiet, who are going to push back. And I guess I would want to encourage providers not to label that as non-adherence right away, or to label those people as difficult patients. There may be difficulty involved in working with them, and also it's terrifying to be approaching, life-altering diagnoses. It's terrifying. And some people are going to, in reaction to that, reach for a little more control. So all that's to say, like, I think, keeping a consistent message, like coming back to a central message, often does actually help to build some trust. Like, she keeps saying the same thing, so there must be some truth in there. Her message isn't altering. And then also helping people know what the next steps are going to look like. Like, here, you're going to go to the cancer clinic next. This is what that intake process kind of looks like. These are the providers that you're going to meet next. Like, those might be some places to help anchor them a little bit more. I do think that handouts and paperwork have their place too. Like, if emotions are really high in a moment, this is something they can take with them when they have a little more of a settled headspace to look at. And that's something that, like, I do in the room too, is to just sort of say, well, let's kind of go over what you learned. And, some of the other things that I'll try to advocate that people do is to organize your stuff in a central place. Like, get a notebook together so that you can take notes at visits. I see caregivers do that a little bit more than patients themselves.
That's what I'm picturing. Like, literally in my hypothetical here, the wife, she has a notebook. The patient doesn't. He takes more of a back seat.
Well, there could be a lot to unpack there too, in terms of like gender roles and, culture and background, and all these things matter in terms of how we approach healthcare, and how we see ourselves as either advocates for ourselves who have to kind of stick up for ourselves, and what our needs are, or people who are just going to, let themselves kind of roll through the experience in a little more passive way. Lots to unpack there. Yeah.
And that's why, I just really like, again, to just go back to like some of the practicality of like a workbook in that hypothetical situation, that couple, I do see how much it wears on the caregiver. And so I think that something like this, even like a joint exercise to be done together, or where the patient can fill out their answers and give that to the caregiver, it's like any amount that we can unburden them, that is a hard position to be in. And like, not to blow up, Colin's spot too much, but I do have a husband who, if left to his own devices, could easily just go to any doctor's appointment, be very pleasant and agreeable the whole time, and leave with no information and like no diagnosis or, like next steps as to like what is going on, with the thing that brought him in. And so we definitely, like, I think that my heart even extra goes out to the caregiver in that sense, because I can relate to like being a spouse who, nothing, I know of very little that's worse than like seeing, right, your family, like your partner, not feel good. Like, I totally get that. And I do think that that does make me, I think that patients and their caregivers see that in me, because I'm not really shy to be like, yeah, I mean, if you were my family, then I would probably favor this. Like, I think what you're doing is very reasonable. You know, that kind of rhetoric.
Yeah, I think it's, you know, one of the things that just struck me as you were talking is how frequently we are in all three of these roles at one time. Like, we can be a healthcare worker and a patient and a caregiver, all the things. And I think that can give folks some real deep empathy around the different corners of this experience. And it's almost laughable to have written this workbook, because we are all going to be in these roles, really, like at least the patient and caregiver side, like we work with those roles. All of us do. And we all have a body, you know, and at some point that body is likely to interact with the healthcare system. So this workbook could really be for anybody. And I think where we can, as a culture, be a little more aware is that, you know, I guess one way to put it is that even within medical systems, you know, there's the part of the Hippocratic Oath that talks about do no harm, not in that exact language, but first do no harm is sort of the principle that we all get taught. And really what we're operating out of is first save lives. And some of the mechanisms we have to do that are not harmless. Like, so we need to kind of come into medical systems recognizing that, whether we're a patient or a caregiver or a provider, right? And then do what we need to do to let it be okay to ask questions and to advocate. And hopefully, you know, providers listening in can say, okay, so that person who feels like they're pushing back in the visit, what they may actually be trying to do is to understand what's going on for their body and reckon through their value system in order to make a decision about what they want with their care. They may be reckoning with the ways in which trust has been damaged with systems in the past, right? Depending on our history of oppression, we may not trust systems to work for us or people in positions of power to protect us. So there can be a lot of that going on. Certainly changes, and I know you're going to get to these parts of the treatment process too, but changes to esteem and body image and, you know, trying to grieve the person we thought we were or our healthy identity, like all of that can come into the picture here too. So anyway, the hope is to give people some skills to be able to organize themselves around a medical experience, advocate for themselves within it, clarify what they want for themselves, and then, you know, and also just recognize that these conversations are not easy. So along the way, we got to find our feet. There's just to kind of be there for a minute. There's a book by Ronald Epstein called Attending, and he talks about mindfulness work too. And he talks about how before he goes into an exam room, he will find his feet. That's one concrete thing, you know, before he goes in there. So
yeah, I love that. Or like, you know, anchoring hand on the door frame or things like that.
Yes.
A lot of tricks, because we do have to reset like 30 times a day. Go talk to, do all these visits. I think that I hadn't thought about that, but that was such a beautiful point that you made about one person being like the provider and the patient and the caregiver, because it's very true. Like even last year alone, I underwent surgery. I was a patient. You know, I was the spouse of a person who underwent surgery, and I was a surgeon. So, and the first two make me a better physician and surgeon. You know, when I was 20, I always joke about when I was 20, I was like, I'm going to live forever. And I would have been a worse off, you know, provider for that mindset. So I want to wrap up the point in time that we've been on, which is where the patient is coming in for a post-op visit, the diagnosis is done, the staging is done. We already know like what the treatment plan is. You know, it's going to be chemo radiation. We're getting you off to care. And to your point, yes, I use a lot of repetition, and I really try to focus on like what's effective. I try to focus on like, hey, absolutely, this is not metastatic disease. Like maybe it's just really locally advanced, but should be curable. Absolutely. We're going to treat you with the intent to cure. And this is what that treatment entails. And I do tell everybody, although I don't harp on it, number one, because I'm not trying to really be a downer. And number two, I'm trying to keep my message simple, like what you mentioned. But I will kind of allude to, but I wonder if maybe I'm not doing like the deep dive work here. But again, so, I'll say, look, absolutely, this is with the intent to cure, let's get you onto treatment. And I will say, I would like to see you back after treatment. I absolutely, please focus on yourself. Radiation treatment is going to be every day, 5 days a week for 6 weeks. Like you're going to be really busy, chemo's weekly for a couple weeks. And I'll say, I want to see you after. And I will say there are many significant long-term side effects of those treatments. And I'll go, again, and I'll, I'm a good resource repository of knowledge. Like I'll say, it will affect your swallowing. Absolutely. This could affect your voice, right? Like, I mean, of course, depending on the primary and stuff, but for this specific case, like especially swallowing and voice to an extent. And I'll tell them, and I'll be like, and radiation effects keep playing out over time. Yeah. Unlike surgery, it's not going to be where you have a surgery and then you just recover from the big surgery and you just get a little bit better every day, more or less. Like the radiation effects, the dryness, like I said, I don't harp on it, but I kind of mention them because I want them to have the info, but I also don't want to be a downer at this visit. So I'd love to know if, and let me just jump forward in time, but I'd love to know your take on all of this, because then what happens is that they go on to treatment. And of course, this is a huge burden on the patient. It's not easy to undergo chemoradiation. It's a huge burden on the caregiver because, as I just described, I mean, that's a full-time job almost, right? Like you have to be somewhere every day, 5 days a week for 6 weeks. It's not very long of a session, but that's just an enormous commitment. Like almost, no one can have a job or have like really do their regularly scheduled routines and now take on this treatment burden. But what happens is at the end of all their treatment, I don't necessarily always wait for the 3-month post-treatment PET scan. That's how we find out if they have responded or not. That's a standard of care. But let's say like around that time. So maybe they finished all their treatment on June 1st. I am seeing them now August 15th. This is like a routine checkup in clinic. Actually, I think maybe the 3-month is pretty good. So here's what's good about the so maybe we have a quick visit at that time. The patient is kind of fatigued, but like their spirits are buoyed by the fact that they have completed treatment. They're like, it wasn't easy. I got through it. But let's fast forward to the 3-month post-treatment visit. Let's say the PET scan's negative, as in this person has had a good response to treatment. Like this is like win. All the party balloons, like we are very happy. They survived therapy. Looks like they had a good response.
Yeah.
And for the purposes of this story, I'm condensing time a little bit because imagine that we're at 6 months. That's going to be even worse. But let's say it's somebody who is starting to have complications of treatment at the 3-month visit, which is that they're telling me I'm so dry, like legitimately, I cannot, my mouth is so dry. I still haven't been cleared to swallow. They're not letting me swallow. I'm like getting nutrition via a peg tube and I'm so dry. So they're very uncomfortable. And it's tough because I will tell you from the provider standpoint, and again, these are all 15-minute visits. So this is another 15-minute visit where I'm going to congratulate every single person who has a clean PET scan at the 3-month post-treatment visit. That is like by all medical parameters, a huge win. Yeah. Yeah. And then now the patient is in poor spirits, understandably, because their swallow is not where they thought it was. And again, the xerostomia, the dry mouth, like those post-RT effects are definitely extremely bothersome to people. And we know that it doesn't take that much radiation to cause permanent damage to the salivary glands, which are in the radiation field.
Mm-hmm. Yeah, that's disillusioning, isn't it? Like for that person, to come through the whole treatment process and then to still have lingering effects. It's really hard.
I mean, sometimes they may even feel worse at this point. in the sense that like maybe they didn't have like, another common presentation of this is a painless neck mass for these HPV base of tongue cancers. So, I mean, that person, other than having a large neck mass that they didn't know why it was there, they weren't like suffering in a symptomatic way. And so now these are a host of new symptoms. And it's like, yeah, we try to focus on the positive, which is that like, I mean, you just had a great response. Like your cancer looks like it went away with treatment,
Right.
but now they're grappling with this. And so I guess I find that part really challenging as the provider, especially because like this is still us sticking to, for the sake of simplicity, like the good case, quote unquote. This is when everything like really went according to plan.
Yeah.
Because guess what? The swallowing difficulties, the dryness after radiation treatment that's all according to plan. Like, I don't know anyone who has really escaped those side effects, right?
Honestly, like in some ways, the cases that go according to plan are a little harder, I would say, because then the expectation is that life is going to return to normal now. I did the treatment, everything looks good. So there's a little bit more of a gap in expectation. Like, I don't know if that's been your experience, but if there have been complications the whole way through, then people might just be like, oh, here we go. They're continuing.
Yeah.
And so part of where, in therapies like cognitive processing therapy, part of what we look for is how a potentially traumatic event either confirms previous beliefs or blows them out of the water. Right. And so if the previous beliefs are, I'm medically complicated and this treatment process has been hard and now there's just more hard, that's a kind of different animal than everything was going really well and now it's not. Right. And so depending on the presentation, right, any of those things can be its own difficulty. Like it's hard when you've had previous traumas to have another trauma.
Right.
It's hard when it's your first trauma. And so I think it just pays to kind of be aware that as you're walking into that room, if everything's been going okay, maybe there's some room to acknowledge that, like, this is a really hard moment. Like, you've been doing everything right. We've done everything right, quote unquote, as a team, and it's still impacting your life. And just to reflect that reality might be enough to help that person feel heard and seen and understood.
Absolutely. I mean, that makes sense. And then what I think is really difficult about this, though, and why I like using this example is because people will ask me sometimes, okay, well, when is it going to get better? Right? Like, or this fibrosis of my neck after radiation therapy to the neck. Like, I mean, we always start people in PT early. This goes back to the multidisciplinary pieces that we've talked about. I mean, like, absolutely, there are things that can be done, but it is tough because at the end of the day, like, we know that radiation therapy is actually pretty mean. We know what it does. We know that it has these long-term effects that like continue to percolate, not abate. That's just like not the natural course of how people respond to that treatment. So I guess that if it's okay, I just want to fast forward to one last time point, so we'll use the same set of people, and we're at the 2-year post-treatment mark. This is even more awesome. Like, and again, we're saying in this scenario, they've never had any evidence of like recurrent disease. So we are 2 years post-treatment. The rules in head and neck is that at 5 years post-treatment, so you have your treatment end date, 5 years after that, no evidence of disease, like you are cured. So at that point, if you don't want to visit your ENT again, that's okay. You don't have to, but we know that the recurrence risk is the highest in the first 2 years. So that 2-year mile marker is a big deal. I congratulate everybody. Like, I'm always like, that is worth celebrating, So we made it 2 years post-treatment, no evidence of recurrence. And to varying degrees, people will be at that place where they want to celebrate. But again, using this example of the guy where like his caregiver is still pretty fit and active and well, and he was well before this whole process. Now at the 2-year mark, again, I mean, neck fibrosis has set in. Their taste is not the same. That's another big one. Like when we look at the head and neck, of course, like so many important critical functions. So like when your taste never really comes back right, your mouth is dry all the time, and the swallowing. I mean, now he's eating and drinking orally, but again, like nothing really tastes right, and it does get stuck a lot. So that's the point that we're dealing with. And so I'm the provider, and I'm being faced with still these questions about like the dry mouth and the dry mouth. And we've talked about all the biotin products. We've talked about all like the different supplements. We've talked about even there are some prescription meds to help stimulate saliva. But that is a really tough point. And I guess I'd love to know how I can be doing that better, because yes, I use repetition. I try to be positive, but I also am a realist. So
Right.
I won't tell people like, you know what, give it another year and all these things will resolve. I mean, that would be crazy. Like, I don't have evidence that in just 1 year, these changes will reverse.
Yeah. Yeah. I mean, I think depending on the patient that you're looking at too, there can be different levels of kind of openness to having a conversation about how some things may not change or improve. But I also think if we don't have that conversation in some cases, like people will continue to expect that things are going to get all the way better. So there's a bit of a handoff that as the medical provider, I think we need to improve a handoff with our culture in general and how we deal with our own internalized ableism and our expectations around what health means and looks like. And some of it is, I mean, even embedded in our definition of health is some pretty black and white thinking. Like we're either completely well or we're completely sick, but there's a lot of nuance in between there. Usually we fall on a spectrum of ability. And so for people who are coming into the medical system, expecting to come out of that system completely well and healed on the other side, by which we mean there's zero disability, I think culturally we need to recognize that that's not what's going to happen usually. Like when the body has been challenged in some kind of way, there's going to be lingering effects of that. Some things may never return to what they were before. And there's no current ritual for hair loss because of cancer treatment or loss of a swallow or, the things, loss of youth, loss of innocence, like these different things that we do lose along the way as we age, as we wrestle with our changes to our body. And so I mean, I think there's a question mark in my brain around like how much you can expect yourself as a provider to be able to hold all of that. Like we all need to hold that better. It can't just be the doctor in the room or the nurse in the room who's responsible for helping a person recognize and realize that we change, that none of us get out of this experience alive, right? And so we do the best we can. I think, we can always say like, hey, I hear you. Things are still not back to what they were. What does that mean to you? What's that like for you? You don't necessarily have to say anything. You can just listen to them for a little while. And actually some research has shown that even just a few minutes of quiet and listening can go such a long way to helping a person feel like, okay, my doctor gets me. They get me.
Yeah.
So maybe that's the end is really that question. Like, what has this been like for you? Yeah.
Yeah, I'm excited. I'm going to try this out because that's very well said. And that would be a new question for me. But I'm very interested to see, how patients respond. I will say that, I think you hit the nail on the head in terms of like the broader cultural conversation. I do have a lot of conversations about the natural aging process in clinic.
Yeah.
I have that conversation most days I am in clinic. And it's because, for instance, I see a lot of presbylarynges, which is aging of the vocal folds and the voice, and also a lot of presbycusis, which is aging of the ears, the nerves of hearing, things like that. But I spent a lot of time being like, wear and tear caused this. I mean, even things like TMJ in older people who maybe have a lot of wear and tear on their TMJ joints. But it's interesting because a lot of what you're saying really resonates to me, not just even in the cancer world and conversations, but I mean, like a lot of the pathology, pathophysiology we see are byproducts of wear and tear and aging.
Yeah. And it's just, we have work to do there, I think. I think it speaks to how strong our healthcare system is that we have developed these expectations that we should be able to age with no
unscathed.
Yeah. Yeah. I mean, we've made incredible advances in medicine, and ultimately we are still mortal humans trying to navigate this life, right? So, we can't just put that in a corner forever. And I think that's where it helps to find supportive people who can approach that conversation around what it means to be a human, to approach death and dying in a way that is hopefully centered in some way in who we want to be and the experience we want to have while we're here.
Wow. Well, that's so incredible. I want to end by inviting you to share any final thoughts or really sentiments about your upcoming book. I think that I of course cannot wait to read it, but
yeah. Well, thank you. Thank you for that chance. So I think main things, so the book will be available on February 11th. My hope is that it provides a mix of practical tools and also just really approachable examples of how to apply them in medical systems and environments to help us all start to have more healing conversations. And so mindfulness is certainly not the end all and be all kind of tool, but it really helps with awareness building. And that's what a lot of the research shows can be helpful in navigating aging. Some of the things we talked about today is like coming back to a practice of regulating the central nervous system and being able to have conversations that are intentional. So hopefully it's a trusted companion on the journey. That's all. And I appreciate every person who reads it very, very much.
Thank you so much. Yeah, it's incredible because truly, I even implement a practice where how do I stay regulated for a difficult meeting that I don't want to go to, right? And it's I've never even thought about for this maybe difficult visit, whether I'm a patient, a caregiver, or a provider. So incredible.
Yeah. Thank you.
Well, thank you so much, Christen. It is such a pleasure to learn from you today. Where can our listeners find and connect with you online?
Awesome question. So my website is ginkgoleafhealth.com. That's GINKGO, leaf like a tree and health like what we're hoping for, .com. And we've got some other cool offerings coming up in the new year too. Just to put a quick plug in February, we're also going to be starting a caregiver grief group for moms who are parenting medically complex kids. And then we do our RISE program too for people who've been through adverse medical events. So there's always new stuff we're doing. Come visit us online.
Follow me on Instagram at francismay.md and at Rethinking Residency. Visit my website, rethinkingresidency.com, to learn more about resident physician stories and ways that residents can most effectively navigate the game of residency. Thank you for tuning in to this episode of Promising Young Surgeon. If you enjoyed the episode, please subscribe, rate, and leave us a review. If you'd like to submit any questions for future episodes, email me at pys@heyinfluent.com.